My name is Jeff DeBerry. I am a senior online admissions counselor for Alliant International University. I'm very happy to be here to present our speaker, Dr. Randall Tackett. He's going to be speaking on the science versus pseudoscience of medical cannabis, what clinicians need to know. Dr. Randall Tackett received his PhD in pharmacology and toxicology from the University of Georgia. After completion of a postdoctoral fellowship at the Medical University of South Carolina, he returned to the University of Georgia College of Pharmacy as an assistant professor. He is currently a professor and associate department head in the Department of Clinical and Administrative Pharmacy and the director of the Clinical Trials Certificate Program in Regulatory Affairs. He also holds adjunct faculty appointments at Alliant International University and Fairleigh Dickinson University. He has given numerous lectures about dealing with adverse drug interactions, cardiovascular disease, substance abuse, psychopharmacology, and forensic pharmacy. He is recognized as an expert in pharmacology and toxicology and substance abuse. So I will give you the floor, Dr. Tackett.
Well, thank you very much, Jeff. I will confess to you that I used to say that marijuana would never be legalized in my lifetime. And that's one of those things that I tell my students never to say never. Just like when I left the University of Georgia with my doctorate, I said I was never going to come back. And I've been here, I think it's 44 years now. One of the things that's prompted giving these talks is medical associations have been contacting me specifically because suddenly their states are legalizing medical marijuana. Even though marijuana has been around for a long time, the question is, what do we need to know? And there's a lot of misinformation out there. I've put this statement up ever since I've been doing this talk, even before the medical associations. And I think it sort of gives a good background of what we're dealing with. E.A. Carlini basically said in 2004, very few drugs, if any, have such a tangled history as a medicine. In fact, prejudice, superstition, emotionalism, and even ideology have managed to lead cannabis to ups and downs concerning both its therapeutic properties and its toxicological and dependence-inducing effects. So that is, in fact, what we're running into. As we are looking at the landscape of legalizing medical marijuana, some people want it legalized for the medicinal aspects of it. And as I will talk about tonight, there are therapeutic aspects there. When we talk about marijuana, I'll be using the term cannabis a lot because we have several different components, not just the Delta-9 THC. But we also have people that want the medical marijuana legalized with the idea that if medical marijuana is legalized, it'll make it easier for recreational. Some people think it's much better as a medicine because it's natural. People have compared it's safer than alcohol for recreational purposes. So there's all these different agendas that are going around. What I'm hoping to do tonight is to give you some foundation because even in states where medical marijuana has been legalized, one of the things we're learning is clinicians don't really know what they need to tell their patients. And a lot of people have gotten information regarding marijuana off the internet, and some of that information has some truth to it. Some of that information may have no truth to it whatsoever. And some of it may be sort of in a gray area, a little bit of truth and a little bit of maybe not so much truth. So when we look at marijuana, from a standpoint of medical marijuana, when you're dealing with the lay public in particular, there is a distinction between recreational and medical marijuana. I even have students here at University of Georgia who basically have been arrested for marijuana because they're going, well, it's legalized. And I'm going, yes, it's legalized for medical purposes. It doesn't mean it's legalized for recreational purposes. So we see that there is a distinction between recreational versus medical. With any drug, one of the big considerations that we have to take into place, if you're going to prescribe marijuana, if one of your patients are taking marijuana for medical purposes, there is still the old aspect that we do for any drug. What is the benefit versus the harm? And hopefully at the end of this, I will have given you some examples of where benefit may occur, where the harm may occur. And you're really making a risk assessment if you are one of these people that are either going to prescribe marijuana or one of the people that may be using marijuana. And then the other thing that just sort of throws a lot of confusion in the mix is states have different laws versus federal. We had a gentleman not too long ago that got arrested for marijuana possession. I was contacted and his argument was, but I have a prescription. And there was two things wrong with that. One is that prescription was good in the state that he got the prescription for. And secondly is, to my knowledge, none of our street vendors, the guys that are selling marijuana in the corners or in the parking lots, require a prescription. But he thought as long as he had a prescription everything was fine. That is not always the case, but it adds to a lot of confusion. It adds to a lot of issues where patients may be given medical marijuana in one state, but there's an issue with getting it in the other state. The other thing that has come into play when we talk about cannabis, marijuana, is we have the CBD. CBD is in most states legal. We see CBD present in a number of different venues, such as vape shops. We even see, for example, one of my students was using CBD, and I asked them where they got it from, and they were getting it from the Tractor Supply store. I've even seen CBD in the pet food stores when I go get, pet food for my dog. There's a whole line of hemp CBD products. The issue is that the FDA probably does not even know how many particular CBD products are. We also see that CBD and the term hemp are used a lot for marketing. So a lot of products are yelling or basically advertising that they are hemp-based or they're CBD. But we do see there are probably well over 1,000 different products that people get through the internet. They get through dispensaries, pharmacies, national retail stores, and some of these boutique shops. So there's just a lot of places. There's been very extensive media coverage about CBD, and there is an estimate that international business, it's probably in excess of $60 billion. So it's a very lucrative business. It is being used to add to the advertising of a lot of things when people are saying they put a little bit of CBD in it. I've seen vitamins that now say we have CBD or hemp. When we talk about CBD, when we talk about cannabis, we talk about THC, healthcare really was unprepared for this, okay? And we see that now. For example, in some states, they have legalized medical marijuana, and I've gone to those states to give talks because they need to know, what do we need to know about this? And my bottom line is, well, I can tell you a lot about it, but the reality of it is, although your state has legalized marijuana, it does not have any recognized dispensaries. So even if the state has legalized medical marijuana, you have no place to get it. One of the things was that THC was a Schedule 1, and that produced a lot of regulatory roadblocks for us doing scientific studies on those. The other issue that comes into play is street marijuana, the same as what we would see from, that we would get from a dispensary or whatever. And then CBD, which gets sort of mixed in there. Basically, we've had very limited studies that actually have looked at CBD alone. So there is a limitation of the studies. Now, we've had recently a drug that was approved in the last several years, Epidiolex, which is the first botanically extracted CBD product or cannabis product. But the issue was a lot of our safety studies and so forth are based upon that. Regardless of this limitation of information, we see CBD and cannabis and hemp products touted as pretty much a cure-all or a panacea for just about everything. If you look at the number of diseases that supposedly are treated by this, people talk about that it's effective for anxiety. It's good for cannabis use disorder, Crohn's disease, diabetes, epilepsy, Huntington's disease, Parkinsonism, opioid use disorder, schizophrenia, psychosis, cancer, sleep disorders, pain. There are studies that suggest that cannabis, THC, may be therapeutic. But on the other hand, we have to look at what we're getting in the marketplace and how pure it is and what the dose is. So when we look at cannabinoids, first of all, our body we have some endogenous cannabinoids. We refer to those as endocannabinoids. They basically are derived from arachidonic acid. Arachidonic acid is basically the precursor for prostaglandins and thromboxans and several other endogenous components. So we do know there's an endocannabinoid system and that it serves as a modulator for other transmitter systems. When we look at phytocannabinoids, these are plant-derived cannabinoids. There are hundreds of naturally occurring compounds in cannabis sativa. This includes THC. It includes cannabinol, also includes cannabidiol. Those are the ones that seem to be the central component, but these others sort of get lumped in. And then we have synthetic cannabinoids. These are basically laboratory-produced congeners of THC and CBD. Now, some of these synthetic cannabinoids can be pretty nasty. Since we've had legalization of medical marijuana, a lot of people think that all THC is the same. So phytocannabinoids, THC, Delta-9 that comes from the plant is similar to what you see with synthetic cannabinoids. And some of these synthetic cannabinoids are pretty toxic and have some pretty negative things. But people think about synthetic as we've just made it in the laboratory. So we have to be careful about that. If you look at the different cannabinoids, what you're going to see is everybody is familiar with THC, and specifically the delta 9 THC. The delta 9 is the product that's psychoactive, produces the euphoria. Increased reaction time means it really takes you longer to react. We've seen some loss of memory and cognition. We've seen several negative aspects of THC. What we have to be aware of is delta 9 is the one that most people are aware of. We're also seeing that delta 8 and delta 10 THC are showing up. And the reason they're showing up is because of the Farm Bill, which allowed hemp products to be marketed. So one of the biggest things that I'm running into, especially with professionals, professional students, they're using gummies and they're buying gummies from, various different places off the internet, Tractor Supplies, I've said. And those gummies are legally sold. But one of the things we're seeing is, although they have CBD in them, they're also being spiked with delta 8 and delta 10 THC, which is creating a problem. Delta 8 in particular can have some properties similar to THC. It's not quite as potent, but when you see the amount of delta 8 that gets put into these gummies, it becomes significant. Cannabinol basically is been touted as being analgesic. It's been used to improve sleep. There is laboratory data which suggests that it promotes the growth of bone cells and may actually promote healing and maybe even be something that could help in osteoporosis. It is anti-inflammatory, anticonvulsant. It's an appetite stimulant. The big one we see that comes out is CBD. And there is something about CBD that is very positive. CBD has been shown to modify the THC effects. In other words, it will antagonize some of the negative aspects of delta 9. Often, most states have the laws written that say that you have to have a certain amount of CBD. Usually it's in about a 1-to-1 ratio. CBD also will prevent the conversion of THC to the 11-hydroxy-THC, which is an active metabolite. And we don't see formation of CBD from THC. It doesn't occur necessarily from smoking or by metabolism. We do see CBD as a pretty good anti-anxiety drug and can also offset some of the psychological side effects that we actually see with delta 9 THC. The other compound that I have down here is carboxyl THC. It's inactive, but this is what stays around. One of the things that happens when people use THC, one of the metabolites that happens is the carboxyl, and that will flag a drug test. When we see people that are smoking heavily or using THC heavily, this carboxyl metabolite, the inactive metabolite, can stay around for several hours or days. In fact, in very heavy chronic users, it's estimated it may stay around about 30 days. So this basically would tell us that someone has used marijuana, but it doesn't tell us when they used it, and they're not under the influence of it if this is all that is present. When we look at THC, the cannabinoids, as pharmacologists, what I do is we always want to find, one is, are there receptors for it? And two is, where are those receptors? So what we know, and this has been known for a good while, is that we do know that there's CB1 receptors that are located in various aspects of the brain. And for example, in the medulla, in the cerebellum, the basal ganglia, the cerebral cortex, the hypothalamus, the hippocampus, and the spinal cord. There are some things that are involved in those particular areas that we know anatomically those areas control. And so if those receptors are activated or stimulated by THC or cannabinoids, it gives us an example of how the drugs may work. So for example, we do know that people under the influence of marijuana may have difficulty moving. They could be staggering. They can have difficulty walking, things like that. And we do know that by activating receptors in the basal ganglia and the cerebellum, that would account for the movement disorders that we have. We know that marijuana can affect cognition. We have CB receptors in the cortex. We know that one of the big things that always comes up is marijuana should be legalized because of its antiemetic effects, that it is a very good drug for inhibiting nausea. We'll come back to that. The hippocampus is where, as most of you know, learning occurs, and that can affect it, can affect learning and memory. And we do know that some of the peripheral sensation, including pain, occurs in the spinal cord. And that's been one of the things that people have thought about is if we could activate those receptors or interact with those receptors, this may be a good analgesic drug. And we see a lot of CB1 receptors in the central nervous system. And these areas account for the pleasure, the movement disorders that people may have, learning, interference with learning, interference with cognition, and may even alter people's perception of pain. We know that marijuana acts in the reward center, the mesolimbic reward center. So that is one of the reasons that we get the euphoria and could also contribute to the potential addiction aspects of marijuana. In the cerebellum and the basal ganglia, some of the negative things we see is lack of coordination, clumsiness. We really see this more common in the recreational users. But when we are using this as a therapeutic agent, what we do find is, for example, those actions in the cerebellum and basal ganglia, as well as maybe even the spinal cord, may come into play with regard to relieving spasticity. And so one of the things that we have seen therapeutically is these cannabinoids are useful in some of these severe spastic disorders. Mood can be modulated. Of course, everybody thinks that when you are smoking weed, basically you're in just this euphoria, pleasant mood. But we also see that individuals can have some alternative responses other than just being, sort of chilled out and everything. We do see panic attacks. We do see some psychosis that may occur. Again, we have the prefrontal cortex. The hypothalamus, the munchies are well recognized with people that are using marijuana. And again, the spinal cord, especially the dorsal primary afferent tracts, and those tracts going up into the central nervous system may be responsible for the analgesic effects. Basically, looking at pharmacology, we have receptors that are targeted, and those receptors are in specific areas that give us a good idea of what to expect with someone that is using these drugs. Of course, the dopaminergic pathways in the reward center, that is going to be important for abuse and dependence. One of the misperceptions people have is there's a lot of people that say marijuana is much safer than alcohol and other drugs because people don't get addicted to marijuana. But we actually do know there is marijuana use disorder. We do know that there are issues that occur, and that is explained by the actions in these reward centers. Now, another interesting thing is that there's very few receptors actually in the brainstem. So one of the other things that comes into play is because there's few receptors in the brainstem, there's minimal effects on the autonomic nervous system directly by the drug. And in fact, one of the big things was people can say, for example, with alcohol, they can kill themselves by drinking too much. So for a long time, we said there is no known lethal overdose that's reported with THC. Now, we had people that died when they were using THC because maybe they were in a car wreck or some other thing that was secondary, they drowned or whatever. But there's always an exception to every rule. And not too long ago, we did see someone actually overdose on marijuana. However, I will tell you, it was a very, very, very large amount of marijuana. And that was written up, I think, in the New England Journal of Medicine. The other issue that comes into play is, first of all, when we're looking at marijuana, we have to realize that what we would see in the dispensaries and what we grow may not be the same stuff we see on the street. There's some differences in potency and actually maybe some differences in the constituents of this particular cannabinoids. We also know that we can see certain compounds that are present in the raw marijuana, in the raw botanical. We also know that once it is heated, which is a very common way that people, they either smoke it or cook it up in certain recipes, that we can get some other compounds. And then we also may see different compounds once the drug is aged. We can see some slightly different profiles. There are so many different variations of what you may be actually looking at, even in medical marijuana, as to the constituents and the concentration. Now, I'm going to take a step back from marijuana and let's go to, do we have any cannabinoids that are actually available as drugs in the United States? And the answer is yes. One drug that's been around, and it's a synthetic THC. One of the drugs is dronabinol, and it's been around since 1985. And an interesting thing about dronabinol is if marijuana was really as good as everybody makes it out to be, as far as a therapeutic agent, dronabinol would be in the top 300 drugs, and I don't think it has ever been in the top 300 drugs. But in addition to dronabinol, we also have nabilone, and we also have Epidiolex that was recently approved, which was the CBD. So dronabinol and nabilone is THC, where Epidiolex is primarily CBD. In Canada, we have nabiximols, and in Europe, we also had a drug called rimonabant, and that one was actually tried to get approved in the United States. But one of the major issues occurred was in the studies, there were concerns over depression and suicide. So it never got approved here in the US. If you looked at dronabinol, trade name was Marinol. It was actually approved in 1985, synthetic THC, and it was approved primarily for chemotherapy induced nausea and vomiting. And that was a big component that people pushed for marijuana getting it approved is all these people undergoing chemotherapy, they suffer terrible nausea, and marijuana helps alleviate that. The other thing we saw this used for is since THC can stimulate appetite, we found that using this was very good in patients that had AIDS, especially that became anorexic, or even elderly patients that may be suffering from a wasting syndrome. They just weren't eating. So the idea was Marinol was approved to stimulate appetite. In other words, generate the munchies in these individuals. Another drug, THC analog, pretty much the same as dronabinol. What we find is it differs a little bit. One, dronabinol basically takes about 30 to 60 minutes to kick in, but lasts about 6 hours. Alone takes about 60 to 90 minutes, but lasts up to 12 hours. So what we're seeing is variation in the pharmacokinetics, but the antiemetic effect was basically about the same. And the other thing was it was approximate or slightly greater to that we saw with phenothiazines, which tend to produce a lot of sedation. And with these two drugs, what we saw was there was a very narrow gap between the dose that you needed to get the effect and the adverse effects. So in a naive user, they would potentially experience euphoria, which you might say maybe that's not too bad in these patients. But we did see some dysphoria, which we don't want, some cognitive clouding, which could interfere with their quality of life and their ability to do different things. They were drowsy and they were dizzy. And so these adverse effects were more problematic when they first started with it, but as they developed a tolerance, they were able to manage that. A couple of things that occurred with these drugs is even though they're pharmaceuticals and they went through the FDA and were approved and so forth, we did see some variable absorption and some first pass effects. So it really gave us a little bit of unpredictable blood levels, so some variation. But here's where their use really dropped off. As I mentioned just a moment ago, they were more effective generally than some of the drugs we had. But then we had a new drug that came out, which basically worked on serotonin receptors. This was ondansetron, which you guys probably have heard as of Zofran. And Zofran, when it came on the market, it was much more potent, more predictable than these drugs, very minimal psychotropic effects. And we even had an IV dose, which if somebody was really nauseous, you would want to give them that. So the bottom line was ondansetron, when it first came out, was very expensive. I remember my daughter getting some ondansetron after some surgery when we took her home from the hospital. I think they gave us 3 tablets, and each tablet was like $6 or $8. But now ondansetron is generic and pretty cheap. But we don't consider these drugs really first-line agents for nausea anymore. What we find is when individuals don't respond to first-line therapies, that sometimes we will use dronabinol, nabilone, and in some cases people will, smoke weed to get the delta-9 THC. CBD was the other one, and it's in botanical preparation, so it's in the plant. But one of the things we see is that CBD's concentration is in the plant may vary. The big thing about CBD was it doesn't have the psychoactive properties. It actually, we find that THC tends to produce anxiety and paranoia. And if that is already present in a patient, it can actually exacerbate it. And we find that CBD tends to mitigate that. And in fact, we find that it may, on certain things, may actually act synergistically with THC. CBD by itself, in the right dose, may have anxiolytic properties, even some antipsychotic properties. And it has also been shown to have some anticonvulsant properties and some neuroprotective properties. Where we're seeing CBD used now is these spasticity problems. And that's what it was actually approved for, with some of these severe spastic issues. So if you compare THC and cannabidiol, THC can produce the euphoria, can produce anxiety, psychosis, cognitive impairment, and increase appetite or cause hunger. Cannabidiol doesn't produce the euphoria, is anti-anxiety and psychotic, doesn't appear to produce cognitive impairment at most of the doses that we would use, but it doesn't have an effect on appetite. So if we're trying to stimulate appetite, CBD just doesn't get it. Nabiximol, which is Sativex, which is available in Canada, and they've had some trials in the US, this was approved for cancer pain and neuropathic pain, such as in multiple sclerosis. Now, the reason I wanted to bring this up is because I want you to note something. This is available as an oral spray, but notice the concentration. It is about 50-50 THC CBD. It contains both THC and CBD, and this drug seems to work pretty rapidly. Doesn't produce the sedation and memory impairment that you see with THC. And what we find is that the peak concentrations of THC are much lower. It's estimated over 20-fold lower than someone that would be smoking cannabis. So, with a lower level of THC, the belief is there's a lower potential for dependence. A lot of states have in their medical marijuana laws that the compounds that are available should have like 50-50. And then Epidiolex, it's a purified form of CBD, is plant derived. They use it for severe forms of epilepsy and movement disorders. And it was actually scheduled as a Schedule 1. It can't be a Schedule 1 because Schedule 1 says there's no medical use. But it went from a Schedule 1 down to a Schedule 5, one of the lowest schedules we have. But there is a warning for Epidiolex, even though it is only CBD. There's a label warning that you could fail a drug test. You could test positive for THC. So we tell patients that they potentially could test positive for THC on a cannabis drug screen. Any of the drug screens just say THC or metabolites. So I've run into situations where people that have been using CBD, not the Epidiolex, but CBD that you would see in gummies and so forth like that, that have failed the drug test and have lost their jobs or have had to go to court to try to get their jobs back. Primarily, I've seen that in academia, law enforcement, and healthcare. Another interesting thing is these CBD products, which we purchase legally. There was a recent article in the Journal of American Medical Association. They actually got 84 CBD products that they bought from online distributors. 84 products, 31 different online distributors. 70% of those products had different levels of CBD than specified on the label. Half the products had more CBD than indicated. About 25% of the products had less CBD than indicated. In 18 of the samples, Delta 9 THC was present. There was a concern about Epidiolex with its off-label use, people trying to use that to get high by using high dosages. Probably the cost prohibits that because you're looking at about $3,000 per month at a prescription level that you would need. However, people that are using CBD, one of the things that could potentially happen is that CBD, if someone used it off label, wrote a prescription for that for anxiety or something like that, then that could offer some advantages, although insurance is not going to approve it, and it's going to be awful expensive. What we do see with CBD, now this is assuming that we have a relatively pure form of CBD. Most of that has come from the Epidiolex clinical data, and we see that liver enzymes increase and there is potential for liver injury. So that's something we might want to monitor. We do know that it goes through the cytochrome P3A4, and as most of you know, 3A4 basically is one of the most common drug enzyme involved in drug metabolism. And it also goes through 2C19. But we do see that there is the warning that if CBD is used with other CNS depressants, that there may be an increased risk of drowsiness or sedation. So that's sort of just a generic warning that is given. When we look at when you do not want to use cannabis products, ultimately someone has to make a decision that does the benefit outweigh the risk. So typically when not to use it is if, as like with every drug that's out there, if there's a hypersensitivity to it, it's not recommended for use under the age of 25, even though some of the patients are young children that Epidiolex is being used. If there's a history, either personally or family history of psychosis or schizophrenia, cannabis use disorder, or any other active substance use disorder, it's not recommended. Pregnant or breastfeeding, we know these drugs will get across the milk and get into the fetus also. And then if there's any significant cardiovascular or pulmonary disease, that's sort of the general contraindications for this use of cannabis. One state that has given us some interesting information is Colorado. because Colorado was one of the first states that sort of legalized marijuana. In March of 2015, there was a lab that went to the certified growers and sellers. These are the ones that have been approved to grow the marijuana to sell legally and the ones that are selling it. They gathered a bunch of bud, literally 600 samples. The average THC level was about almost 19%, but some of those retail pot samples contained 30% THC or more. When you're getting these products, one of the big things that you got to be aware is you're not sure how much you're getting. It's sort of like, would you take any other medication where someone says, here's your asthma inhaler, and you should be getting, 15 milligrams of this with each puff, but it may be 30 milligrams or maybe a little less. So that is a concern. With medicine, we're wanting to dose, and many things are dose related, and we want to have enough to get an effect, but we also don't want to have too much. The other interesting thing was in these samples, they found little or no cannabidiol, CBD. And remember, one of the things is CBD offsets some of the negative aspects of the THC. So the average CBD amount was like 0.1%. So you had in some samples 30% THC, but only 0.1% CBD. So that was a big concern. Again, not knowing what we're getting, but also not knowing the amount that we're getting. The other thing that comes into play is when we're looking at recreational versus medical use, there's a different method of use. For example, medical, we're going to have gummies. That's a new popular thing. People are vaping. One of the issues is that altering these vape pens and vape pods can create some very serious things. There's impurities that can be in there. That's going to be a big concern. And the other thing is, if any of you grow, for example, jalapeno peppers, if you water the plants really well, that they're going to dilute. They're not going to be as hot. Whereas if you don't water them or you're in a drought, you tend to get those much hotter peppers. Same thing happens with THC in plants. And so one of the things people have said, well, maybe we can have a centralized source of cannabis. I can tell you right now that many people that want to use cannabis do not want the government basically providing their cannabis for them. The other thing is that addiction can occur. So we've got to be monitoring individuals for the potential for addiction and doing the appropriate things for preventing addiction. A lot of contaminants that can show up on the street. We find various fungi and bacteria that may be on products. People use organophosphate pesticides, which you're going to inhale. And on the street, we find that sometimes the products are actually contaminated with glass beads and sand. That increases the weight, and that can be inhaled and cause some serious damage. We do know THC and other components of marijuana, the other cannabinoids, can actually affect neurotransmitters and how cells grow. The question is, to what extent? We know that it can stay in the body for weeks, especially in maternal tissues. There's some dog studies that suggest it may stay there. We know that it deposits in the fat, and sometimes if it's heavy use, it can be slowly released. We know it crosses the placenta. It can go through mother's milk. So there's a lot of exposures that we have to be very, very aware of. The other thing is what we're seeing is concentrations of THC has increased significantly since the 70s, 25-fold. One of the concerns is that in edible forms, the gummies, it may even be even more. From a standpoint of pregnancy, we know it can interfere with folic acid, and we know that animal studies tell us that THC may be involved in development, and these have been done with mouse embryos. Of course, we can't ethically do these in humans. The other thing we saw from the Colorado data, we saw that several patients after legalization were actually hospitalized. They show up in the ER, severe hallucinations, no gag reflex, difficulty breathing, and they were actually getting synthetic THC, and they were being touted as being, again, legal marijuana. And some of these products actually had names on them or logos on them, such as Botanical Sachet, Sexy Monkey, and Crazy Monkey. Sometimes what we actually see being sold as synthetic THC sometimes are very similar to what we see in bath salts. Does it cause addiction? We say yes. We have seen marijuana use disorder. Estimated that about 30% of those who use marijuana may actually have a marijuana disorder. And we see that the earlier they use them, they're more likely to develop marijuana disorder. And typically, we're going to see that there is an alteration in the endocannabinoid receptors. We're now getting some research that is giving us more insight into what's occurring. But again, many people thought marijuana was much safer than even alcohol or even cigarettes because they did not recognize the marijuana use disorder. 10 years ago, we estimated 4 million people met the criteria for marijuana use disorder. Here's something that emerged, and it's a term called scromiting. It's also known as cannabis hyperemesis syndrome. The reason it's called scromiting is because when people vomit due to this, remember, a lot of people tout marijuana as an antiemetic, an anti-vomiting compound. It's so painful that they scream when they vomit. So it's been termed scromiting. This typically occurs in males that are using marijuana multiple times per week for greater than a year. That puts them at the highest risk, although we've seen it in individuals using it a lot less. When they stop the marijuana use, it goes away. It's related to the THC concentration. In the 90s, a typical joint would have about 1 to 3 milligrams of THC. Currently, it's estimated a single joint has 18 milligrams. We don't see this with CBD, but we see it with THC. Couple of slides here, which I use a lot. This is a normal brain on your right. These are some scans. On your left is a 16-year-old that has a 2-year history of daily abuse. These are not physical holes in the brain. They are basically areas where functioning has been decreased. So we do see some pretty significant brain changes, and that is consistent with the pharmacology. Here's another. You've got a 18-year-old with a 3-year history of 4 times a week smoking weed. Again, when we're dealing with this, we don't know exactly how much THC they were getting since this was straight marijuana. And then you can see several scans here showing various use. And here's one with 12 years and some pretty significant brain changes that have occurred. So one of the big things that the medical associations have come to me with is, are prescribers prepared? There's been studies that actually surveyed medical school deans, residents, and their results were 75% of medical school deans said their graduates were not at all prepared or were only slightly prepared to answer questions about medical marijuana. 94% of those same people said that their graduates were not prepared or only slightly prepared to prescribe marijuana. So that is a big issue. And all these things have been touted as having health benefits. And the National Academies of Sciences in 2017 came out and said they looked at the different evidence. And what they said is there is substantial or conclusive evidence that medical marijuana can be helpful in chronic pain, can be helpful in chemotherapy-induced nausea and vomiting, and spasticity associated with multiple sclerosis. With regard to some other things, you have to look at benefit risk with the idea that even with the medical marijuana, you have to recognize there may be impaired cognition, may be an increased chance of motor vehicle crashes because of impairment, addiction, lower birth weight. All of those have to be factored in. But what we find is that insufficient evidence exists for the use of medical cannabinoids for which its use is advocated. If you look at a lot of states, there is over 50 medical conditions that they approve or allow medical marijuana to use, and there's no evidence for it. That's a big issue that we're dealing with right now. There is a lot of compounds which there's not strong evidence for its benefit. Elderly, risk of falls are a big concern, especially if they're using other central nervous system drugs or blood pressure meds. We have no control over specifically, as I showed you the data from Colorado. We don't know what they're actually getting in the dispensaries because most of these states have not established the issues associated with these dispensaries. And a lot of patients can't even tell you how much THC or CBD they're on. I had a patient just recently asked how much on a gummy, and he said it's 50 milligrams. And I said, 50 milligrams of what? And that's all it said on the package insert. So I had no idea was that CBD or whatever. Now, the other thing is we find that what's available, even over the counter, is that products can be mixtures of THC and CBD. They can be THC dominant, so more THC than other things. They may be CBD dominant, which means they're CBD, but they can still have THC. And there may be several other cannabinoids. We just don't know. And the FDA doesn't check for safety before these go out over the counter, but the FDA can step in if there's a problem with that. When you see THC side effects, basically you're going to see nausea, dizziness, increased appetite, euphoria, things we've talked about. Once you get above 20 to 30 milligrams per day, you're more likely to see these. And if the person has not had a history of using it, we're more likely to see it. But a big issue is even with legal marijuana, this is an important thing for you to know if you've got patients on that. If your patient was taking Xanax, you get pulled over, say I have a prescription for Xanax, and because you tested positive for the drug test, then, for example, I write a letter and say this is a prescribed medication, they're taking it, no problem. That doesn't hold for THC. States do not give you the same latitude. And the same thing with drug tests and employers. Employers do not have to maintain or offer if you are using marijuana, even medically. Something very important for your patients to know. Some things about CBD. Typically, at most doses, it does not impair driving. Higher doses, in some people, you might get some mild sedation, but typically it's pretty good. We have seen if people on citalopram or escitalopram, there have been some reports of increased plasma concentrations. So you want to be careful about that. To give you an example, I'm using Alabama because I've just done something for the past 3 years for them. To prescribe marijuana, the prescriber has to pass an exam specifically on medical marijuana. They have to verify the patient has a qualifying condition, which the state outlines, and conventional therapy or medical treatment has failed. The patient has to show proof of state residency. They have to buy a medical card, marijuana card for $65. They have to be entered into a registry. A lot of states are doing this. Minors under 19-year-old go through the same process, but they have to have a designated caregiver, and both the caregiver and the patient have to be registered with the Cannabis Commission and be state residents. They clearly state that marijuana is not legalized for everyone. It's very specific. They recognize that recreational marijuana is still a threat. And if you are possessing, distributing, or manufacturing using marijuana without a license, you're looking at a Class B felony. If you're greater than 70 daily doses, then you go to jail. They can prescribe it up to 12 months. The daily dosage can't exceed 50 milligrams, but can go to 75. But you've got to justify that it's medically appropriate or the patient is terminally ill. If they get 75 or greater than 75, their license is suspended. There are specific acceptable forms. One of the things that's been a concern, gummies, and that's the non-sugar coated gelatinous cube. And there is going to be a state determined flavor for the gummies in Alabama. And I think they're leaning towards peach. Medical marijuana cannot be smoked or vaped. Employers do not have to allow or accommodate it. And you can't sue the employer. If you're fired, you can be considered having been discharged from job because of misconduct. Creates a real issue with certain states. So in the state that you're in, if you're involved with that, your patients need to be aware of that. The interesting thing is there's no registry that's been created. Dispensaries haven't been established. And so literally it's legalized, but really no way to do that. CBD basically can show up, so products can have THC. It can show a positive drug test, as I've said before. One other thing I want to mention, cannabinoids have medical value. They do. Are they superior to existing medications? Not always. And since they are natural substances, a lot of people say they can have no side effects. That is not correct. Every drug has side effects. Not all cannabinoids have the same effects. It depends on what is in each preparation. Just because it comes from state-approved sources doesn't necessarily mean it's consistent amounts of cannabinoids. We've seen that in Colorado. If you have a marijuana card, you're not protected in the workplace. The clinician can write me a prescription for cannabis. That depends on the particular state and what you're looking at. One of the big things that comes into play is CBD. We are finding a lot of Delta 8 and Delta 10. As a result of the farm law passed in 2018, I think it was, basically hemp products were made legal, which generated a lot of CBD, which can be converted to Delta 8. And what we're seeing is on the gummies, we're seeing large quantities of Delta 8 and even Delta 10 being added to the gummies by these manufacturers, which is creating a major issue. And many states are arguing with regard to that situation. Individuals who have TBI, could benefits ever outweigh the risk if impairment is there? That question really comes down to benefit risk on that particular patient. What other options we have and how impaired that patient may be. It also may come into play with how it may affect their overall lifestyle. It will be difficult, I would say, to do that. There are some cardiac effects that are coming out. We're still getting early reports of that. Is the psychosis attributed to the individuals using the wrong strain? Not always. And actually, in my students, I usually give them recipes because they show up on the internet just to tell them what they're having there. I really appreciate your attention and hope you have a wonderful day.
Thank you, Dr. Tackett.
Good night, everyone.